low to moderate vaccine effectiveness against laboratory-confirmed influenza hospitalization among high-risk population in Europe in 2012-2013, a multi-center test-negative case control study, which will be presented by Marc Rondy. Please, Marc.
Good afternoon, everybody. Thank you for reading the very long title of the presentation. So I will speak about vaccine effectiveness against lab-confirmed influenza among high-risk population in a hospital setting on the behalf of the European network taking care of this matter. So as you probably know, influenza prevention strategies in Europe mainly aim to reduce the number of severe cases among high-risk group for severe influenza through annual vaccination of these risk groups. There are actually current ongoing debate about the effect of this repeated vaccination on influenza vaccine effectiveness. In 2011, we set up a European network of hospitals sharing similar protocols based on test-negative design, which allowed us to pool the data together. The objective of this year's season was to measure 2012 and 13 seasonal influenza vaccine effectiveness against hospitalized influenza with laboratory-confirmed outcome in the European Union. So we included 18 hospitals across 5 study sites in the region of Navarra and Valencia in Spain, in Italy, France, and Lithuania. All the patients belonging to the community and being targeted by the influenza vaccination program according to local guidelines, who were admitted to the hospital for influenza-related reason, were screened. They were approached, and we would ask them whether they had an influenza-like illness of the past 7 days. If they had an influenza-like illness, we would propose them to participate to the study. If they agreed, they would be sampled through a nasopharyngeal swab. The swabs were then tested with RT-PCR. The positive tests were the cases, and the controls were those negative for any influenza. We defined the vaccination status as anyone vaccinated for at least 14 days before the onset of symptoms. And then we defined the study period as the weeks comprised between the week of the first confirmed case and the last confirmed case. We defined study period for each of the type and subtypes of influenza, so we had different study periods for H3N2, B, and H1N1. We collected data on demographics, some data on the episodes itself, data about the access to healthcare through the number of GP visits over the past 3 months, data on chronic conditions, quite extensive data, and also on the hospitalization in the previous 12 months, which was a proxy of the severity of the chronic condition. We collected data on smoking status and influenza vaccination. We defined the vaccine effectiveness as 1 minus the odds ratio of being vaccinated among the cases versus the controls times 100. We ran a pooled one-stage model in which we considered the study as a fixed effect, so that it means that we made the assumption that the vaccine effectiveness was the same in each study site. And we adjusted in a logistical regression on age, presence of chronic conditions, and the month of onset. We also defined different vaccination status. So 4 of them. We had a group of reference of patients that were not vaccinated either in 2011 nor in 2012. People vaccinated in 2011 only, 2012 only, and both seasons. Overall, we received 5,000 records, more or less, of which we excluded about 3,000 records, mainly because of the fact that patients did not fit the ILI case definition, or they were recruited outside the study period. We excluded 300 patients because they did not belong to the target group for vaccination, and we had very few lab results missing and very few vaccination status missing. In total, we had 116 cases of H1N1, 58 of H3N2, and 232 cases of influenza B. If we look at the weekly distribution of, the weekly number of inclusions per subtype, you can see that through the season, that was quite a long season, we actually had a constant co-circulation of the 3 types and subtypes in the network of hospitals, with a peak around the week 7. In this table, quite busy table, you can see the characteristics of the cases and the controls. So we will go through it together. You can see that the cases of H1N1 tended to be younger than the controls, and you can actually see that only 14 cases were above the age of 80. We can see also that H1N1 cases tended to have less chronic conditions and less severe chronic conditions. They also tended to be more smoking. H3N2 cases were quite similar to controls with just a different sex ratio. For the B cases, the main differences were in terms of chronic conditions, with patients that tended to have less chronic conditions than the controls, and less severe chronic conditions as well, and they were smoking less. So this is in this slide you see the vaccine effectiveness per subtype, so we will go through it together again. So on the left side you can see that the overall vaccine effectiveness against H1N1 was 21%. But it was about 40% among those patients aged less than 80 years old. We only had 14 cases of patients above 80 years old, of which 12 were vaccinated. For H3N2, we had an overall vaccine effectiveness of 62%, and it seemed that we had increasing vaccine effectiveness with the older age group. We had very, very few cases of H3N2 among those less than 65 years old. And for B, we have an overall vaccine effectiveness of 27%, with the higher vaccine effectiveness among patients aged less than 65 years old. Now, if we look at the vaccine effectiveness according to the vaccination status per subtype, once again, so be careful, we have small sample size, very broad confidence interval here. You can see that the vaccine effectiveness for patients vaccinated in 2011 was more or less the same as for patients vaccinated both years, around 27%, and it was lower for patients vaccinated in 2012 only. For H3N2 and B, we had similar patterns. The vaccine effectiveness was the highest among patients vaccinated in 2012 only, the lowest for those vaccinated in 2011 only, and you had intermediate estimates for those vaccinated in both seasons. Overall, our results suggest a low vaccine effectiveness against H1N1 and moderate against H3N2 and B. For H1N1, we have 40% of vaccine effectiveness among patients under the age of 80, and very few cases, very low incidence among those above the age of 80, with 12 vaccine failures out of 14 cases. For H3N2, the vaccine effectiveness is 62%, and it's higher in older age group. And for B, the vaccine effectiveness is 47% and higher among those aged less than 65. When we looked at the 2011 and 12 seasonal vaccine effectiveness, we saw a very low vaccine effectiveness against H3N2 and B. Here you can see in this table the vaccine strains included in the vaccines of 2011, 12, and 2012 and 13. And you can see that actually the 2011-12 vaccine strain did not match with the circulating strains in 2012 and 13. So there was no real protection to be expected for this vaccine. And we also saw a higher vaccine effectiveness of the 2011-12 vaccination against H1N1, which again could be explained by the fact that the vaccine strain included in the 2011 vaccine was matching with the circulating strains of last season. We also observed a lower vaccine effectiveness against H3N2 and B among patients vaccinated both years compared to patients vaccinated this year only. So that suggests that maybe former seasons' vaccination could induce lower post-vaccination titers in the current season. So the fact to have been vaccinated last year would make you respond less properly to the vaccination this year. There are also studies showing that past natural immunity provides better capacity to respond to current season vaccination. It's a big debate, and our results are just suggestive. We have quite a few limitations with this study. We have quite small sample size for stratified analysis. So the results that are presented here are just meant to be hypothesis-generating results better than firm conclusions, and it's quite hard to interpret the results in the age group with low incidences. We pulled data from different study sites, and we saw some heterogeneity across the study sites. that can be explained by different vaccines that were distributed, also different strains circulating, but also different access to both the vaccination and the care. So in the future, we would love to be able to do a two-stage pooled analysis if we can increase the sample size per study sites. Finally, for the effect of previous vaccination, we would need to have longer history of vaccination for the participants included in the study, and history of natural infection would be really interesting. In conclusion, we saw a low to moderate 2012 13 vaccine effectiveness against hospitalized influenza among this target population, which claim for a more immunogenic vaccine to be developed for those target groups. However, the vaccination remains the most effective prevention measure against influenza. And in the future, we would like to enlarge the sample size to be able to compute early vaccine effectiveness estimates, to compute vaccine type and brand-specific vaccine effectiveness, as well as to further investigate the effect of previous vaccination. I would like to acknowledge all the study sites that were involved in the study in France, Italy, Lithuania, Navarra, Valencia, as well as EpiConcept for their support. Thank you very much.
Thank you, Marc. Could I invite you to sit here with me? And we have 10 minutes for question or short discussion, so please.
Thank you for your nice presentation. I have a question. There were like 1,700 people that were excluded in the beginning. Do you have any information about them, why they were excluded?
Well, about 1,000 of them were excluded because they were outside the study period, so they were negative for influenza, and they were included before the first case and after the last case of influenza, so that was the reason. The others were excluded mainly because they did not fit the influenza-like illness case definition. So they were screened, they were recorded, but they did not fit the influenza-like illness case definition. A very few of them were excluded because they had egg allergies and because they belonged to institutionalized, they were in nursing homes basically.
Hi, it's Jim McMenamin from Health Protection Scotland. I'm going to be very greedy and, with the chairperson's permission, ask two questions. The first question is that you exclude individuals with egg allergy, but there are an increasing number of vaccines available within Europe that are either oval albumin free or have a very low oval albumin. For any future study, will you be considering that?
Yeah, definitely. I mean, we excluded, I think, 2 or 3 patients because of egg allergies. It was a very low number, and I think it's completely something that could be revised according to the kind of vaccines that are produced, yes.
Okay, thank you. And my greedy second question is about the long-term future of projects like this. I can see that there are very nice differences, potentially, between vaccine effectiveness as measured in the community and how that compares and contrasts with those individuals with severe disease who end up being hospitalised. Although I recognise that you acknowledge in part of the limitation that there are differences in admission reasons or admission practice that may explain some of the heterogeneity that you observe between sites. Can I ask, in the longer term, you had a selected number of sites that were providing you with information. In longer term, is there plans to increase the number of sites that can contribute data to you?
That would be very interesting to have pooled estimates and have bigger sample size at the European level. I think one priority is also to increase the sample size per study site. because it would be really, it would be much more appropriate to be able to do a two-pooled stage analysis, and so to be able to basically control for the confounding by study site, because we know it is different, because people have different access to both the vaccine and the hospital per study site. So I think the first aim, at least for next year, will really be to try and increase the sample size per study site. And then, of course, the more we have study sites, the larger the sample sizes at the European level, and the more accurate we can be with the results.
Thank you.
If I understood your data well, it looks like there is a lower effectiveness of the vaccine if you are vaccinated 2 years in a row with the same vaccine strain against that strain. Do you have any explanation about the potential mechanism?
It's more, what we saw from this data is that you had a lower vaccine effectiveness if you were vaccinated 2 years in a row, but not with the same strains, actually. In this case, it's for H3N2 and B, and in 2011 and 2012, there were 2 different strains. One hypothesis is that, to be quite, I'm not specialized in immunology, and I think there is a lot to look into. But basically, when you're vaccinated on year 1, you will mobilize a pool of antibody for the strain that is included in this vaccine 1. That will, and then on the second year, you will try to mobilize those antibody again for another strain, but some of them will still be mobilized for the first strain, so you will just develop a lower protection than if you were only vaccinated on year 2. That's one of the explanations. You also have a lot of papers discussing the cross protection conferred by natural infection. And you have lots of literature these days about that.
Tia Fischer from the Statens Serum Institute in Denmark. Thanks for a very nice presentation. I'm wondering, you didn't present any virology data backing up the findings about the lower vaccine efficacy. And is that because you don't have the data from the respective sites, or is that because it's supposed to be presented in another session? That's one question. And the next one, already forecoming this, if you don't have the data, are you planning to do a future study where you're actually including the virology backup with sequence data, etc.?
This is something we would really like to do, and be able to develop capacities to interpret the data with regards to virological data. I'm not sure there is a need to have data exactly from the same setting, but surveillance data, virological surveillance data from the same region would be good enough. It's also, I think, a question that you have in the iMove network, where they're trying more and more to interpret the vaccine effectiveness with regards to virological data. So that's something we would like to do. Then you will always have the question of how representative is your virological data, because there is no systematic testing and sequencing of the circulating strains. So it's always, but that would clearly be something that we would like to do.
Thank you.
Okay. The topic is very interesting. I'm afraid, however, that we have time only for one question more.
Am I allowed to give that?
Only one.
Thank you very much. A very nice presentation. We've heard some nice presentations on intensive care unit surveillance of influenza earlier during the conference. In your hospitals, are there large intensive care units also serving the population? And could you take a look, specified look at the intensive care unit effectiveness?
We actually discussed several times with those surveillance network, SARI surveillance network, and discuss how we could include them in this network. The problem in the way the surveillance, the SARI surveillance system works in some countries, I'm not sure it's the case in all countries, is that it's very hard to, so that's one part of the question. It's very hard to include the SARI surveillance network in this network because they don't systematically have the vaccination status of all the patients admitted with ILI in intensive care units. Usually they make it to have vaccination status only for positive cases, so it would be complicated for this kind of methodology. in our setting, in the hospitals where we are, we have information about who went to the intensive care units, and it's very, very low numbers. So we couldn't really get any estimates based on the current network. But it would clearly be very interesting in the future to encourage the SARI surveillance systems across Europe to collect data on vaccination status among the negative patients.
Okay, thank you, Marc.